Welcome everybody. A very good morning to everyone. Honorable Chairman, Professor Rifat, Honorable Chairman, Salehuddin Nabi, and the rapporteur, Altaf. Thank you very much for giving me the chance to talk few words about the superiority of rigid over the fiber optic flexible endoscope in the diagnosis and follow-up of upper aerodigestive tract growth. As my previous speaker, Mr. Simon, has spoken here before me, that in this region, head neck cancer is more common than any other part of the world. The reason lying that partially due to poor oral hygiene and due to chewing the betel nut, though he said about alcohol, I don't agree about that. It's more associated with poor oral hygiene and chewing of betel nut, both India, Bangladesh, Pakistan, Nepal, Sri Lanka, and Myanmar too, though it is not within the ASEAN, within the SAARC, however. So let's go to the main topic. Before I go, I introduce myself first. We are the people here. Saiful Islam and the Tuhin too was with me. This is the hospital that I worked 25 years back in the Birmingham. That was my young age. This is the hospital, University Hospital Birmingham. It is the second largest hospital in UK, next to Guy's Hospital and St. Thomas Hospital. Those having 1,200 bed, and this one was 1,000 bed only. This is the hospital. This is the hospital that you remember. My Pakistani brother Izaz is here. Malala Yousafzai, who was shot in the head, was treated here in this hospital. So the second famous hospital in UK. This is the close view. This is the hospital I spent most precious time of my life. And this side you can see the right side. Here the hospital people, Salehuddin Nabi is here too. The red brick color is the old hospital. And this one you can see, this is the new hospital. That I spent, I told you, the most precious time of my life I spent to build up this hospital in Mohakali, Dhaka NICRH. But I love it. This is my private setup where I have some slides here from this hospital. This is what now I become. All my hairs and become grayed up. Anyway, so if I take you back to your early days in the MBBS and medical school classes, what we find difficult, most difficult, we visibly studied six cards in anatomy. That was superior and inferior extremity, thorax, abdomen, head and neck, and brain and spinal cord. I don't know about you, but for me, I find most difficult part was head and neck. But unfortunately, I became the head and neck surgeon. Yet I felt it difficult. However, for the cancer specialist, they have to know all the parts of the body. There is no part immune to cancer. So all the cancer specialists should have know all the six cards of anatomy. So however, today I take you back there. So this one, you know, especially fifth year, that was the Chiron lamp. And Chiron lamp and the head mirror was the key to examine the head and neck. And for us, especially to look through the hole, that was very difficult for us to look. We come to the second one, that is the head mirror. However, now many new systems have been developed, especially the cold light fountain. And really, many times, for you, I don't know, for me, sometimes I made mistake to make the mirror in the head, to look in the hole. And it was very difficult. So that one is simplified by straight scope. But unfortunately, many of my cancer colleagues, I mean those who are cancer specialists having ear, nose, throat problems, especially upper aerodigestive tract, they send the patient to us. They say, you have a flexiscope, what it's called also nasoendoscope. So that's why now I'm showing you here why the straight rods are better than the flexiscope. These are the IL mirror, you know, that you used to heat it up and put it inside and look to it through the eyes. But now this one is simplified by the stethoscope. That is the flexiscope. And here, this first invented in 1950. This diameter of this flexiscope length is 18 centimeter to 48 centimeter, any length it can be, but diameter never less than 5 millimeter. And it must be introduced through nose. It cannot be given through the mouth at all. And of course, once you give it through the nose, you have to have a spray, local spray, to make the nose numb to the patient. And patient complains after at least half an hour to 1 hour that he feel it numb, and some other complications as well. I'm coming to you. This is the stethoscope. Sorry. This is the stethoscope. Backside you can see, one is the camera head will come, another is the light fountain will come. Here you can see the degree. Degree comes down. 70 degree, it could be 90 degree, then it will go further. So you just hold it in the nasopharynx, then you can see the whole hypopharynx, the piriform fossa, the vallicula, the vocal cord, and up to the third ring of the trachea. Very simple. If it is 0 degree, it comes through the front, and then you can see through the nose. This one, I'm just showing you, this is very simplified, very simplified. You just see how it can be seen. This is only nuts. See the camera, you can look to the monitor, see the vocal cord. So easy. You don't need to spray anything. You don't need to let the patient to lie down. See, so simple, very simple. In our study, we had total number of cases, 110. And duration of study was the 6 month. Place of study, 3 tertiary hospital and private hospital. Private hospital is my own. Type of study, it was retrospective. Type of instrument, we use 0 degree, 30 degree. 0 and 30 we use for the nose and the sinuses. Through 0 and 30, you can go up to the sphenoid. You can go up to the base of the sphenoid. And 70 degree, that's what I shown you, 70 and 90 both for the larynx, hypopharynx, piriform fossa, vallicula, those. See one by one. This is one picture. This is the normal one. This is plain. Here you can see huge growth on the left side. And vocal cord left vocal cord almost obscured by the growth. And most of the pictures taken by the straight rod, 2.7 millimeter diameter. And see on the left side of the piriform fossa, there is pooling of saliva. There is pooling of saliva over there on the left side. Same, huge growth on the left side, obscuring the view of left vocal cord. You can see the left vocal cord is almost obscured. The right vocal cord is okay. And these are the pooling of saliva. Saliva, the water, it is showing like this in the camera. Huge growth, see? But this is smooth outline. And see the pooling of saliva. Pooling of saliva here in the piriform fossa. And that is the smooth growth. And this is this two is the vocal cord. And this is the epiglottis. The reflected one is the epiglottis. This is another one. This is left piriform fossa, this is right piriform fossa, and this is the growth. This is the left vocal cord, this is the right vocal cord. This is almost normal one. Here you can see the same one which you've seen before. here, this is not related with cancer though, but I captured this picture just to show you. See, this is the typical vocal cord growth that is between the posterior 2/3 and anterior 1/3. Right. On the left cord, this is the bigger. See here, what is that? This is the kissing nodule. What it is called? This is the kissing nodule. This one, when the person talks, then both opposes together, then here it goes, it gets the injury due to this growth. So here in the span of time, it grows here. And I came across the growth. I removed this growth, the bigger one, and I seen that the report, histopathology report was the stage 1 cancer, but the basement membrane is intact. And we removed it. The patient, this 22 years back, I did it here in this country. And very famous person. And still he is alive. But he got the radiotherapy. So benign looking can be malignant too. And this, here you can see another growth. Here you see huge pooling of saliva. This is the right cord, the growth here. Here, huge pooling of saliva. And this is the epiglottis. Same. Huge pooling of saliva. Epiglottis. Left cord, right piriform fossa. It's not very obvious. This is the growth. This is the piriform fossa. Huge growth. Vocal cord cannot be seen. Small growth on the left cord. Some pulling of saliva. Here is the growth. This is the epiglottis. And this is also, this is the base of the tongue, growth in the base of the tongue. Small growth here, but arytenoid region is so much swollen, the growth is here. So you can see very huge growth. Both the vocal cord opposed. Nice. This is the part, some growth here. This is the growth, epiglottis. This is full of growth. The left piriform fossa. It's all like this. So if I just go faster, because already Altaf gave me the bell, but I won't take much time. Here another, this is the growth and this is the piriform fossa, see pooling of saliva here. It's another. So like this you can go, we can see so on and so forth. This is another one, it's closing the. So here just you see, requirement of anesthesia, flexible required, rigid not required either. Oral application not possible, this is possible. Nasal bleeding frequently occurs here, very rarely or no at all. Video pharyngoscopy only for video pharyngoscopy, just you see. Video pharyngoscopy usually not needed for cancer, it is usually needed for hemiplasia or paraplasia. Where we put the nasoendoscope, we put in the nose and let the patient to drink something. Then we just make the video, whether there is any leaking or not. He could close the oropharyngeal and hypopharyngeal sphincter or not. For that only, flexible is needed. Other than that, flexible is not needed. And of course, you should think about the patient compliance and the cost. Cost flexible is higher and this is lower. Even I make some discount for you, but still I cannot make less than rigid endoscope to the flexible endoscopy, because flexible endoscopy is more expensive and it is more easy too. So whenever you request your ENT colleagues to follow up the laryngeal and hypopharyngeal growths, you just tell them, have a straight rod and to have the endoscopy through that, not through the flexible one. So that is the take-home message for you. Thank you very much for giving me the time, and thank you all. Bye.